All right, go ahead.
Okay. We are a meeting of the Oversight Council and we have a quorum. But before I ask about the minutes, I want to welcome Lauren in your new leadership role. This is great. I think everybody is terribly excited and delighted that you are here.
Yes, thank you. And I'm really excited to be joining the council meeting today from the CHIA side, having joined the CHIA team and now here for almost 3 months, which is hard to believe.
Yeah, well, you have a little more time to say you're newbie, but not really.
Yes.
And it's wonderful that you actually know something about the organization. Much easier to walk in. So that's great. Okay, I believe we all got a copy of the minutes from the last meeting. We have to do a roll call because we are on Zoom, but does anybody have any concerns, questions, or additions or deletions? Hearing nothing, I will ask for a vote to approve. I will go, if you don't mind, down my list so I can make sure I check everybody out. Okay, Laura.
Motion to accept and yay.
Brent.
Second and yay.
Thank you. Lauren, nope, you can't do it because you're now not on the council. Got it. Niels.
Yes.
Thank you. Martha.
I'm going to abstain since I wasn't here for the last meeting.
Very good. I was actually going to say that and I had forgotten that. If you weren't here, then you can abstain. Meredith.
Yay.
Okay. And Colleen, that's a great question. I don't know if you can vote for the person who was indeed here, but I believe you can.
I can, yes. I vote yes. Thanks.
And do we have Sandy? Sorry.
Hi, yes.
Great, Sandy. Okay, minutes approved. I now turn it over to our new executive director for her report.
Great, thank you. And good afternoon, everyone. It's really nice to see everybody. And sort of for the new members, welcome. It's great to have you on the CHIA Oversight Council. As I put in my email, there's a number of sort of work stream updates that are currently in flight. We've been hard at work on a number of different initiatives over the last couple of months. Turns out I joined out at one of the busiest times here at CHIA, but it's been sort of baptism by fire, and grateful for the team who has been patient and really sort of helpful and supportive as I've gotten acclimated here. But as I had sort of laid out in my email, there are a number of work stream that are ongoing, and that for today's meeting, I wanted to just provide a brief update for the council and tee up some future discussion questions that we really are looking for the council members' input and feedback on to help sort of inform and shape the direction of these various initiatives. So again, the goal for today's meeting is to sort of highlight and preview some of the ongoing work at CHIA across these various work streams, tee up some discussion questions for you all to think about, and then at the next council meeting, we'll do a little bit deeper dive into each of these areas. For the remainder of the meeting, want to just sort of provide a brief update on where we are with the legislative process, CHIA's budget process, and where it sort of fits in within the broader legislative and governor's budget process. Just touch on sort of how we're thinking about some strategic planning work. And then the two sort of substantive agenda items today. We want to provide an update and overview of where we are with the EAPCD project. If you don't know what that is, we will provide a brief sort of recap for some of our new council members. And then finally, we want to provide sort of the key highlights from our annual report. As many of you know, is CHIA's sort of most cross-cutting publication that we released last week. So with that, we'll sort of dive into the work streams, the 3 work streams that we wanted to highlight and preview today. Happy to sort of take any questions on them, but also know that we will have an opportunity to sort of discuss in more detail at the next council meeting. All right, so Alex, can I ask you to please pull up the slides? Great. All right. So here I've sort of laid out the 3 initiatives that I wanted to highlight. The primary care dashboard, as we know, this is sort of investments and sort of strengthening the primary care system has been sort of a key priority of CHIA's and sort of the broader policymaking on the broader policymaking agenda for a couple of years now. CHIA began measuring primary care metrics a couple of years ago and released a report last fall on investments in primary care, and then this January released its first inaugural primary care dashboard, which really provides an overview of the health of primary care, the primary care ecosystem in Massachusetts, and it covers and it tracks metrics across 4 domains: finance, performance, which we really sort of bucket access and care into that performance bucket, capacity, and equity. And so I think, again, we can go into more detail at a future meeting, but some of the things that we're thinking about now and that we would love to get feedback from the council on are what additional metrics and domains should we be looking at when we're tracking the health and the capacity of the primary care system. And in this sort of in the same vein, at the time that we started collecting primary care data, we also started collecting metrics on behavioral health. And I think there's interest in creating a behavioral health dashboard as well. So looking at what are the various metrics and potential domains would we want to include in a behavioral health dashboard? What's important in terms of measurement to help inform policymaking and recommendations around investments and the like. So again, these are sort of just general questions for the council to be thinking about, and that we would love to get your feedback on at a future meeting. Let me pause to see if there's any initial sort of threshold questions on this one.
Maybe for those of us that don't spend all our time on this, when you say the ecosystem, what does that mean?
Sure.
I know this is obvious, but we're looking at every primary care doc office, every community health center, every.
So we are looking at, when we say ecosystem, I think we're looking at not only sort of the workforce capacity. So that is one of the metrics or one of the domains when we talk about capacity. But we're also looking at what is the general quality also looking at it from the patient's vantage point. So what are the quality ratings going up or down as we look at this year over year? Is the access, is it harder to get in to see a primary care doc now than it was, say, 2 years ago? And of course, equity, I think this is something that we're layering the equity lens and trying to find additional areas to layer this equity lens onto, and the primary care work is one of those areas. So looking at, are there disparities in terms of access quality for that are based on sort of geographic region or various demographics. So I think when we use the word ecosystem, we're not solely looking at like the primary care physician workforce. We're looking at sort of the 360 view of what it means to have a strong primary care system in place. Does that answer your question?
Yeah, thank you.
Lauren, a question about, in thinking about, I mean, you can't turn 10 degrees in any direction and not get slapped with something that has to do with AI or ChatGPT. And just thinking a little bit about what's the juxtaposition of all of that? I've been spending the last year of my life working on this, and it's going so fast and exponentially. It's really quite shocking that notion that we develop technology at a far greater rate than we can comprehend is really kind of happening. And I'm thinking about what role that plays in any of our future topics or work streams. And maybe that's not for today, that's another discussion. But thinking about also issues of, at the NAM, we're working on questions around in really assessing and measuring health equity using such metrics as race, which just logically based. And so, we've sort of, and just thinking about some of those, will some of those discussions take place somewhere within CHIA, not necessarily here, but just wanted to ask questions about kind of the things that are not so much on the horizon, but are here on the doorstep.
Yeah, no, I think that's a great flag. And I think in some ways it actually sort of plays into each of these three work streams here. And so what I'd potentially ask is that for you to perhaps sort of put that topic and put a pin in the topic, so that when we do some of these deeper dives, we're asking the question of how does AI impact the primary care delivery system, and are there metrics we should be, if we say, for example, that it's improving access or improving the capacity, are there metrics that we should be thinking about or incorporating into our measurement to be able to get a better grasp on how AI, for example, is impacting either positively or negatively the primary care delivery system?
That honestly feels to me like one of the most important roles that CHIA can play, because as we watch the complexity of regulating or controlling or whatever the inputs, we talk about transparency and things like that. When these deep neural networks we don't even know, even the creators don't know how it generates the things that it generates. We're really the rubber's going to meet the road in looking at when these are unleashed, when these are implemented. We really have to become a learning health system, maybe for the first time, to understand what's actually happening as a result of those going out into this ecosystem in this world. So I think this is one of the most important areas that CHIA can look into, and it's vast and it can become overwhelming. And I'm not suggesting that we go face first into this, because I think you can get lost in this, and the rest of your metrics pale in comparison to the complexity and challenge. But I really am happy to hear that we'll have a chance to talk about it in the future.
Yeah, no, and I would sort of look to your sort of expertise to help us think about across these areas, which are sort of thematic areas that we feel like are sort of the most pressing and urgent issues of the day facing our healthcare system. And so would look to your expertise to sort of weigh in on how can we, CHIA, sort of make sure that we are, even if we're not sort of passing a judgment on whether AI is good or bad, but how do we sort of capture this development, this development that's rapidly evolving in the system, from a workforce capacity, from an equity capacity. So look forward to sort of hearing more from that lens or from that angle at future discussions.
Sounds great. Thank you.
Yeah. And I think a lot of us have an awful lot to learn at this point too.
Yes, yes. Any other questions on the primary care piece? Okay. So with respect to workforce, I think this is something that I think it's hard to participate in any healthcare conversation these days without the issue of workforce coming up. It is, I think I can confidently say, the most pressing issue facing the healthcare delivery system, and impacts really all sort of spectrums of the healthcare sector, from the long-term care space to hospitals to home health. It really runs the gamut, and I don't know that I've heard of any sector that is, has an oversupply of staff and workforce. So there are a number of efforts afoot right now trying to grapple the workforce issue. But one of the challenges to date has been each different trade association or industry organization, like the Mass Hospital Association, the Association for Behavioral Health, the Mass Senior Care that represents long-term care facilities. They were each sort of respectively doing their own survey and collecting data on their own niche sort of sector. But we at the state level had no sort of foundation or centralized source of information and data on healthcare workforce. So this was one of the areas where I felt like it was an imperative to really prioritize and commit resources to conduct an annual, for CHIA to conduct, working with partners at JSI, to conduct an annual survey of provider organizations, key provider organizations within the healthcare sort of umbrella category, to track and monitor capacity and diversity, recruitment, retention strategies, things like that. So we are planning to field this survey on an annual basis. We are planning to field this first go around between April and June of this year, with reporting out coming later in the fall and calendar year. In addition, well, let me just to sort of pause on the annual survey. So when I say looking at a cross section of healthcare sectors, we have a list of 10 sectors and sort of setting types that we are looking to survey or incorporate as part of this annual survey. So it includes hospitals, behavioral health providers, long-term care, physician groups, home and community-based services, EMS, dental, adult day health, and ambulatory surgery centers. So it's sort of some of the major key provider groups within the broader healthcare workforce umbrella. And as I mentioned, our plan is to sort of publish data through a dashboard and summary reports based on the information collected through this survey. In addition, we are building capacity to field ad hoc, what we call pulse surveys, that to focus on sort of specific topical areas and sectors. And again, this would be on an as needed basis. And would allow us to sort of drill down on if we knew that there was particular challenges facing one of the particular healthcare sectors, we could field and turn around survey results in a more sort of expeditious manner. And I think that is really to help with in policy making and coming up with strategies and solutions to address sort of more immediate term challenges. So one example that I know that came up even during my time at EHS is there was some elements of seasonality to staffing challenges at long-term care at nursing homes. And summer was always more challenging. And so if in a given year, we saw another, God forbid, another COVID surge coming, like the Delta variant that hit in the middle of July. And we know that there's some elements of seasonality that compound staffing challenges in long-term care. We could issue a pulse survey sort of going into the summer to assess preparedness and help sort of whether it's the state and or the industry make sort of more like time sensitive decisions around and strategies to help with augment and bolster their staffing ahead of the summer. So we're sort of just building the capacity to do pulse surveys. We're not sort of presupposing that we have to do a pulse survey every year, but it's sort of like an intermittent optional tool that we will have in addition to the broader annual survey. And so when we have that larger discussion with the council on workforce, I think some of the things that we'd be looking for council feedback on is the future refinements to the annual survey. So this first go around will be our first inaugural survey, but very much want to hear from the council and other key stakeholders on areas and opportunities to refine it. We would also be interested to hear ideas as to specific topic areas and sectors that could be ripe for these pulse surveys. So let me pause there to see if there's any questions on this work stream.
I'm a little curious about what sort of questions, so how the organizations are being asked and what sort of questions you're asking to sort of ascertain capacity and sort of what their capacity and sort of workforce needs are.
Mm-hmm. So I think some of the questions, and I would defer sort of the next sort of some of the more granular details on sort of like what questions are being asked and how they're being sort of framed to that deeper dive discussion. And I'll make sure we have the sort of the relevant team members here at CHIA to speak to more detail. But there will be questions such as sort of what's your vacancy rate? What's your turnover rate? What are you offering in terms of recruitment or retention bonuses? Things like that.
Yeah, that makes sense. Thanks.
Meredith.
Yeah, I was going to say also for non-physician and non-billing staff, the question of wages is a critical one because obviously workforce shortages go along with wages. So it would be great if we could learn a bit about what's happening. Are we seeing wages increase for the staff where we have these great shortages, or is there some reason that the wages are not responding?
Yes, yeah, and I think that is definitely an element of the survey, looking at sort of the economics and monetary aspect of it, but it's not the sole focus. So the survey does capture sort of, and we'll be able to capture trends in wages, but also other recruitment and retention tools like bonuses and shift pickup bonuses, things that we know that providers are sort of throwing everything against the wall to get staff in the door. And so looking at what strategies are being employed and what strategies are effective, because I think that part of this is let's have one centralized source of truth on what's happening in the healthcare workforce that we can track year over year and take sort of best practices and take strategies that are working in given sectors and making sure that other provider types are employing those strategies that do work.
So I think this will be an interesting conversation because you've got a lot of different ways you can go and a lot of different ways that people can answer. And there's the what strategies work versus the actual data on the salaries. And frankly, a lot of the questions that you were thinking of may not be quite as easy to get as you think in terms of data. And I'm assuming you're asking the large provider groups. Is that who you're asking when you say provider organizations? So this isn't you're asking the Mass Medical Society. This is you're asking, Brigham.
Correct. So we are going right to the providers versus the associations. The associations, though, I will note, have been helpful in sort of facilitating, getting member buy-in and facilitating sort of contact information and the like. So the associations are also supportive of this effort because it means that they no longer have to sort of be the sole sort of channel, or they don't have to field their own surveys to the extent that we are able to capture data and information on their sectors.
I'm going to switch to Martha, who has her hand up. Thank you, Martha.
Hello. One other thing I was wondering is this going to be including just private providers, or would this also include DMH, DPH, facilities, Mass Health, people who contract with Mass Health? Just curious about how that would get layered in. I don't think you could necessarily really break down by payer, right? Because some people might do a mix, but wondering how that might be captured as well. So we can get an idea of how the state workforce versus the private workforce is working together.
So I know we have been in touch with state partners sort of around the initiative more broadly, but I don't believe, and I will let some of my colleagues tell me I'm incorrect here, but I don't believe we were contemplating including DPH and DMH hospitals sort of in this first go around, but we would be happy to have that conversation. I think we're trying to balance where are we looking for sort of cross-cutting data and information, but also being very mindful of burden. We don't want to be sort of putting administrative burdens, reporting pressures on the providers, the very providers that we know are strained.
Laura.
Do we give any customized reporting back to, so I might be really inclined to do this as a provider if I think, gee, I'm going to be able to say you are here and other people's wages and salaries are, it would really give me a much more granular and I think reliable look into where I sit vis-a-vis the market. Obviously the rest of the market blinded. Do we give those kinds of kind of customized reports back to each reporting group, or is that not something that they would get as a result of and obviously CHIA, if we ask for it, then it has to be given, but would there be a value add for them?
In terms of knowing the precise wage amounts?
In terms of knowing where they sit vis-a-vis others. So they would, and they'll take a look at it and they'll see how it ranges and they know their own values. So I think one of the benefits here is they could easily say, we thought we were doing really well and we realized that we are way behind the curve, or there may be some value in it for them to be able to level set or at least get a sense of the context in which they're operating and how they stack up.
Yeah. Yeah. And I think that is something that we could certainly do and think about when we're putting together the data dashboards, for example, is that we could almost, I'm picturing something akin to our relative price charts where, you know, we report out on the median and we have sort of dots across like the spectrum of here's the lowest wage for a given position at a hospital and here's the highest wage, and without necessarily naming the facilities or the specific providers, it would allow providers to see sort of where they fall based on that range. And I was corrected that we are looking to try to capture some state hospitals in this survey. So those conversations with colleagues at DMH and DPH are ongoing, and we know that they are certainly not shielded from the workforce challenges.
Yeah.
And have it even tougher.
Yeah. Thanks.
Thank you. Any other questions?
I'm also being told that we're planning some benchmark reporting by sector. So I think that goes to your comment, Laura, around being able to sort of display the data in a way that not only is sort of informative for policymakers, but will also be informative and useful for the providers themselves as they're thinking about different strategies and solutions towards their workforce shortages.
Great, thank you.
All right. If no other questions on workforce, again, it's something that we will circle back to. We're looking forward to participating and joining HPC's workforce event next week on the 29th. And, happy to sort of continue to share and provide be a resource through this data collection efforts as the conversations around the healthcare workforce continue. All right, and the final work stream that we wanted to provide an update is with respect to health equity, and there's a number of things that are ongoing that sort of fall within this bucket. One, she's been partnering with Mass Health and MHA on an initiative to collect enhanced sociodemographic information to support or in support of Mass Health's equity program that was sort of established under their 1115, recently negotiated 1115 waiver. So in order to do this, she is standing up a platform to collect or pull, I think it's the technical term, data from hospitals' EHR systems. And we are essentially collecting certain data specs, RALD, SOGI specs on behalf of Mass Health to implement one of the elements of their 1115 waiver that essentially provides incentive payments for those providers that are moving the needle on health equity and addressing and reducing health disparities. So this is again an effort that we're partnering and doing on behalf of Mass Health, but we feel like there's a lot of opportunity if we can get the system up and running to be able to pull data from hospitals' EHRs. It will allow us to sort of opens the door for potential new analytic opportunities, and sort of streamlines that data collection process by, again, just being able to sort of pull directly from the EHRs. So that's one initiative under this umbrella category. Another area is as many of you will recall, in 2021, CHIA launched a series that highlights the ways in which health insurance coverage, access to care, utilization of services, and affordability varies by race, ethnicity, family, socioeconomic status, geographic location, and disability status. And sort of through this brief series, we've released a total of, to date, 4 chart books and research briefs as part of the series. We have 2 more planned for the spring. One that sort of relates to rates of insurance coverage among foreign-born versus U.S.-born residents in the Commonwealth, and another on the relationship between race, ethnicity, and hospital utilization. So we will continue to sort of release these research briefs and analyses with respect to health equity, knowing that these are many of the questions that that policymakers and stakeholders are trying to grapple with as it relates to healthcare, because we know that there are disparities across all of those metrics that I mentioned on affordability, utilization, coverage, and the like. And then finally, sort of more broadly, with respect to health equity, we're looking at other ways to enhance data collection on key sociodemographic information, and it's in our existing data collection systems. So through case mix, we're the APCD, we're also including updates to the Massachusetts, one of our flagship surveys, the Massachusetts Health Insurance Survey. And so that the updated, and what we call it, the Massachusetts Health Insurance Survey, the MHIS, the updated version of the MHIS with the SOGI enrolled questions will be fielded this April. So we will have that fully sort of incorporated into that coverage data, and will enable us to sort of, again, continue to layer on that equity lens as we're releasing and additional reports and publications, as well as identifying other opportunities for analysis. And then sort of the last thing I would just note is we're sort of looking for opportunities and standing ready to support related efforts in this space. We've already been in touch with the Health Equity Compact, which is a conglomerate of key providers, health plans, other sort of community leaders in this space. And so sort of stand ready as a resource through our data, information, analytics to support their efforts. So again, happy to sort of dive into any of the various sort of sub work streams at either now or at a future meeting. But I think one of the things that we're looking for council feedback on is from your various sort of vantage points and areas of expertise. Are there additional opportunities and ways in which CHIA could support health equity initiatives, whether it's sort of taking a closer look at some opportunities with AI, as Laura had mentioned? Are there other ways that we can sort of cut or analyze the data to help support certain questions, targeted questions related to health equity? So I think that's wanted to put that on the table to sort of tee up for future meetings, just some of the ways that we're thinking about how can we sort of leverage all of your expertise to help inform how we support the various health equity initiatives that are ongoing. Any questions?
Yeah, thank you. It was a good discussion of the work streams and a lot more to be talking about.
Yes,
future.
yes. This was just supposed to be a brief preview. But certainly there's a lot to talk about, within each of these various areas. So more to come, and we'll make sure that you have these slides just so you can be thinking about some of the areas that we'd love to get your feedback on in the future.
That would be great. Thank you.
So the next item on the agenda, or part of the executive director's report, and Alex, if you wouldn't mind advancing, is on the legislative and budget updates. So I will turn it over to my colleague, Emma, who will walk through these updates.
Thank you, Lauren. Alex, if you don't mind going to the next slide. Perfect. So the new legislative session started in January, and over 6,700 bills have been filed in the House and Senate. Specifically, there are 64 pieces of legislation that directly name or would have an impact on CHIA. This includes new data collections, reporting requirements, and participation on commissions and boards. Some general themes of these bills are healthcare affordability, access, financial transparency, and health equity. And then we are also closely monitoring bills related to pharmaceutical costs, primary care, behavioral health, and hospital acquisitions. We're keeping a close eye on these bills, either because they have been debated in a previous session or they have been flagged by legislative leadership as a priority this session. And then just quickly moving on to an overview of the status of the FY24 budget. On March 1st, Governor Healy filed her FY24 budget proposal, also referred to as House 1. It included a $33.394 million appropriation for CHIA, which represents a 3.07% increase from FY23 and fully funds CHIA's budget for the next fiscal year. Regarding next steps, CHIA is scheduled to testify next week before the Joint Committee on Ways and Means. Also scheduled is the Council's annual budget hearing on April 19th, where the public has the opportunity to submit testimony on CHIA's proposed budget. And then this spring, the House and Senate will release and debate their FY24 budget proposals, which will be eventually reconciled in a conference committee.
Can you just refresh my memory? When you say CHIA is expected to testify, what do we testify on the budget? I mean, the budget.
So the Ways and Means, the Joint Committee on Ways and Means holds a series of budget hearings every year. So I believe I think the HPC is at one today. So they've already kicked off, and that provides the opportunity for agencies to talk about what their budget request is, what's kind of on the docket for the next fiscal year, priorities, ongoing projects.
Okay, so it really, it's not so much a request, it's more of a, here's what we are going to be planning to do. I was struck by this. It seems backwards. If there's a budget hearing on April 19th, but we've already testified on the 28th, I'm not sure, other than providing information, does it get voted on? I mean,
Emma,
So, if you want me to,
I'm obviously not in government.
no, that's okay. Our line items are set by the governor and the state legislature,
Right.
even though we're fully funded by the industry. So we go out and collect the money, but it does get set there. We actually don't have a budget hearing process. That was a late breaking add to CHIA statute, 5 or 6 years ago, Lauren. So it is a little weird, but it is a request. So Lauren will have to go and ask for that line item.
Okay, all right, but it is, okay.
It's it's a process.
One other thing to add is the Joint Committee on Ways and Means sets the budget hearing schedule. And so I would say that CHIA has to appear at the time when the Joint Committee sets the hearing date for that thematic day. They split it up by category. So there's like
I think we're having a little trouble hearing you with your microphone, or is it just me?
Oh, no, I'm sorry.
There, much better. Thank you.
All right. Yeah, so just as a note, just also the CHIA doesn't pick the day necessarily of when they testify.
I assume they would not.
Yeah, but that could be a little bit more, kind of explain the timing of the two.
Okay.
Yeah, I think of it a little bit like I don't know if this will help the way that you're thinking about each of the two hearings, but the Ways and Means hearing, I sort of think of CHIA's opportunity to go and sort of make the case for the line item appropriation amount to say, this is what we need to sort of fully fund our operations, to sort of ensure continued sort of maintenance and or take on new initiatives. And then the CHIA, the CHIA's sort of own personal hearing that is scheduled for mid-April is sort of an opportunity to hear from stakeholders. I think oftentimes we hear from those stakeholders that are the assessees, so those paying in, to say, here's how for the stakeholders to share how they feel about CHIA's budget and how we should be prioritizing the budget.
Thank you. Sorry, Emma, go on.
Oh, no, that was it. Thank you.
Thanks, Emma. And no, thank you. It's an important question, and I think a helpful one to sort of level set for, particularly for new council members here. All right. So the last item on the executive director's report, just wanted to sort of briefly touch on this. This is certainly falls in the category of more to come, but as executive director, one of my top priorities here is to ensure the agency is maximizing its value to both stakeholders, sister agencies, and align its resources accordingly. I think to help advance this goal, I'm working with CHIA's executive team to develop a strategic plan, and that will help guide CHIA's priorities and organizational decision-making. So we are planning to kick off those strategic planning efforts next month in April, and expect to bring a draft proposal, or straw man, if you will, to the council for review and feedback later this spring. So we are sort of in the early stages of this, but wanted to just flag for awareness for the council, and flag that we would be bringing you sort of a proposal or draft strategic plan to get your input and feedback on later this spring, probably the May-June time frame.
Lauren, will that the pre-work to that, or the input work to that, include going beyond the staff and maybe to those that fund and those that pay the assessment?
So I think that we are not quite there yet, but I think that is a good idea in terms of coming up with some channel or forum for the stakeholders and assessees to be able to weigh in on how we're thinking about the various priorities, making sure that we're aligned, and making sure that there's some alignment in terms of how we're prioritizing resources to meet those various priorities and goals. So I think that's a good flag, and we will, as I mentioned, we're sort of still in the infant stages, but once we kick that off, we will build into our process and plan an opportunity to solicit feedback. And I think perhaps one opportunity doesn't necessarily need to be the sole opportunity, but one avenue could be sort of more targeted or pointed questions at the budget hearing, where stakeholders will be attending anyways.
Yeah, that does sound good, like an intriguing opportunity. Thank you.
It will be dependent. I'll caveat that it'll be dependent on whether we are sort of ready by the 19th to be able to sort of tee up those questions. But I think either one way or another, we will make sure that we're providing some sort of input process for key stakeholders, and particularly those that are paying into our assessment.
Yeah, I understand it. It's no small feat to do it. Yeah, so sounds easy. It's hard.
Yeah.
Indeed. All right, so that is it for the executive director's report, and the two remaining items are around the EAPCD and the annual report. So I can sort of tee up the EAPCD agenda item, and just to sort of level set for new council members. And I would welcome the opportunity for those for those that are new and want more details, because this is a bear of a project. So we are happy to sort of spend some more time with you, really diving into the details if you're interested. But sort of at the highest level, All Payers Claims Database is CHIA's largest data asset by an order of magnitude, and it contains more than 5 years of highly granular claims data from more than 80 payers plus Medicaid. So CHIA has been engaged in a lengthy capital project with IBM to standardize and enhance the analytic capacity of the APCD. So we've dubbed the project the Enhanced APCD project. So while the Enhanced APCD is currently accessible right now, there are several elements of the development work that are still underway and that we're looking to get across the finish line this spring. In order to make this happen, meaning to exit the development phase and move on and shift focus to the operations and future enhancements, we have reset expectations and established clear deliverables and milestones with IBM. I've also deputized Jamie Reed, who is our Senior Director of Customer and Data Product Support here at CHIA, to serve as CHIA's primary point and lead on this project, and whom I've asked to provide the council with a project update today. So I will turn it over to Jamie, and we'll make sure to save time at the end to ask any questions.
Hello, everybody. As Lauren stated, my name is Jamie Reed. I'm a Senior Director in the Data Operations and Technology Group. I'll be providing you an update on the Enhanced All Payer Claims Database project. I know some of you are familiar with it and some of the newer folks may not be, so I'm just going to give a quick high-level summary to kind of get you up to speed, and then we'll dive into where we are now. Next slide. A little more. As Lauren already stated, the APCD is our largest asset. It includes member level enrollment files as well as medical, pharmacy, dental, and vision claims for approximately 50% of the commercial market. This excludes most self-insured accounts following the 2016 U.S. Supreme Court ruling. Data is submitted to CHIA in a pseudo de-identified way that allows the agency to understand how individuals move throughout the healthcare system without holding PHI. CHIA does extensive work to manage the de-identified data, normalize it across many submitters, version final claims, track people over time and across plans, and add analytic enhancements to the raw claims data. Next slide. So we kicked off the project to enhance the APCD. This is to standardize and add analytic enhancements to the APCD. It increases analytic capacity by including industry recognized groupers, hierarchies, methodologies, etc. It helps to improve result consistency between users through standardization. And it provides an online interactive solution. It removes IT burden for sister agencies to transfer, load, and store the Massachusetts APCD, enable a wide range of users to easily and efficiently produce reports, queries, and data visualizations via Tableau, provide ready access to data model documentation as well through training on data model and reporting solutions. Next slide. So we have partnered with IBM to create a system that can accept our APCD data and enhance it to be even more analytically useful. Through things like IBM's flexible analytics software, we're able to add layers to the data and create a more robust data set. And with a Tableau interface, the more non-programmer type analysts have direct access to the data. We're very excited about what this system will be able to provide the analytic community and will give us more tools to be able to report on our healthcare system and look at it from new angles. I look forward to seeing what the new enhanced view will look like for our state. As some of you know, this project has gone on for longer than originally expected, but I think that we're in a really strong position right now as we have a system that is built and functioning. It has usable member eligibility and claims data, and we are adding additional enhancements to make it even stronger. With the initial build out of the system wrapping up, we look forward to producing more reports and enhancing the data even further. IBM has been a good partner for us in the sense that through all of the challenges, they have continued to show up and provide resources to help keep things moving forward. So in resetting the project, Due to a variety of things, we felt like the project was in a position to do a bit of a reset to get through this last round of enhancements. So we worked closely with IBM to take these last items and organize them in a way to help get them over the finish line. The first thing that happened was that IBM has provided us with a new account manager that comes from the IBM corporate side. And with him, he brings a new pool of resources that he can source from to add support to the project. To better support the work on the CHIA side, we reviewed the current workload and parties responsible for the work. In the past, there had been several parties managing pieces of the project, and we decided to streamline the management of this to ease the burden and avoid multiple lines of communication. So that is where I have come in. I'm now the single point of contact on the project so that we have a full grasp of all the different pieces. And I serve as the conduit between the two groups to keep all communication traveling on one channel. This keeps things clean and makes sure that we're all on the same page. We've also instituted a new version of our weekly project meeting with key representatives from CHIA and IBM. We have used this forum to compile a complete list of deliverables and schedule by which we've asked IBM to complete them. IBM has refined their reporting to us and provides us a detailed status report every week, including percentage of work done, any challenges they're facing, and what is up next. We can discuss issues at this meeting, as well as having the right people there to make decisions on the spot when needed so that we're able to save time. Next slide. So the current state, that's bringing us up to today. We are very close to completion with the last pieces of development due to be finished this spring. We're currently working on adding a risk adjustment grouper to production, getting a completed suite of documentation, and putting a lot of our focus on performance improvements. The system looks good overall, but currently isn't returning queries as quickly as it should. So we're reviewing how it was implemented and working to find ways to improve it in order to have optimal performance. IBM is also working on moving flexible analytics to the cloud. The expectation is that this will provide them with the ability to turn around data faster to CHIA. We have also achieved submitting and processing data on a quarterly cadence. We now have claims paid through September 2022, which means we can begin exploring healthcare patterns from the first half of 2022. And lastly, IBM is reviewing the current documentation to refine and compile it into a final version that can be used to help train new users. Next slide. So putting the EAPCD to use. We have been able to start using it internally for some efforts that we've worked on. So I'm just going to walk you through some of those. We've started to use it for the hospital payment equity report. This project helped us compare prices for a set of procedure codes for certain services. Essentially, we were able to see if the prices were different in hospitals that serve different communities. We are currently using the EAPCD to work on our annual prescription drug report. Previously, we had to use internal resources to link various tables within the APCD to external pharmacy data before analysts were able to conduct analysis. With the new system, this data is already linked, and we are able to use the Tableau interface to work with the data and manipulate it right away. As part of the FY23 budget, the legislature included a requirement for CHIA to produce a report examining mass health payment and utilization rates for telehealth services, as well as the analysis of the utilization rates of telehealth services where in-person services are available. CHIA used the EAPCD to compare payment rates and utilization for in-person services and their telehealth counterparts. CHIA additionally compared telehealth utilization rates for various services between Mass Health members and the commercial market. The other thing that we've been able to take advantage of is using the system for exploratory analysis to assess feasibility of supplementing summary level data. This allows us to use the system to do quality checks on our work. We were able to do this while preparing the annual report. We were also able to use it to look at trends and help to design future analytic work. Next slide. Transitioning to the next phase. As we wrap up the current deliverables, we're looking forward to being able to share the capabilities of this project with others through reporting and partnering with our sister agencies. As we continue to add new data on a quarterly basis, we also look forward to reporting on more current data submissions over time. Our focus right now is improving the overall performance of the system so that when additional people are accessing it, we will see faster results. We are now working with the HPC to get them into the production environment and having meetings with them to flesh out their use cases. Additionally, we are adding them to our Tableau analytic work groups so they are able to learn with us how to best utilize the tools to enhance their reporting as well. We will continue to explore the system and build new ways to report on our healthcare system and devise future enhancements to the system that will continue to help us grow and evolve the type of analysis we are able to do. Thank you.
Great. Thank you, Jamie. And I just want to sort of reiterate how grateful I am that Jamie sort of stepped into this role. I felt like it was important to have sort of one point of contact, one lead, sort of accountable for all of the various moving parts related to this project, because as I mentioned, it's a massive project and undertaking. This has been going on the project has been underway for years. We are very close to the finish line with respect to the development phase, and our goal is to cross that finish line by the end of this spring, so that we're fully moving and shifting into the operational phase. And so I would just sort of echo that as CHIA moves from the development phase into the operational phase, we'll be looking for the council's feedback on ongoing operations. And sort of more importantly, input on new analytic enhancements and functionality that you all would like to see as part of the EAPCD project going forward. So let me pause because I see a couple of hands.
There will definitely be questions.
Yeah. See a couple.
Actually, I think Sandy, yours went up first.
Thank you. Thank you so much for that presentation. I was just wondering about the hospital payment equity analysis that you described. I wasn't aware of that work before, and I wonder, is that a current report or forthcoming report that CHIA is putting together, or is this kind of behind the scenes work that the CHIA team is doing?
So this is a project with Manat that is ongoing. We would be happy to follow up with you to discuss in more detail if it's something that you're interested in. But we're really supporting. I think this is an initiative that Manat is leading, and we're supporting by providing the data.
Got it. Yeah, I'd be interested in following up. Thanks, Lauren.
And we may want to loop Manat in because they're sort of taking the lead, and we're providing data for their requests.
Neil.
Thank you. On that same slide, you were talking about prescription drugs and enhancements to prescription drug report. Just wanted to see if you could talk a little bit about that, because the reason I'm asking is because earlier you had talked about health equity and certain ideas that we might have about what areas to look into, and I didn't know if maybe that would be an area that would be useful to identify where there might be a need to identify health equities as it relates to prescription drug use and kind of different categories of drugs that are used by different categories of people, depending on their what they have for certain uses, depending on if they're, for example, HIV/AIDS kind of medications or other types of categories where there might be an opportunity to look into health equity.
Yeah, and I think that's a great call out in terms of layering the equity lens. I'll have confessed that I probably know enough to be dangerous here, but my understanding is the prescription drug report is something that we've issued before a couple of years ago, and our plan is to refresh it later this calendar year. And it does look at utilization and spending trends with the different cuts by payer type, different populations. So I think that it's a great call out or flag to think about how can we layer that health equity lens to sort of make this report even more robust and comprehensive than it already is. So it's something that if you'd be willing, we'd be happy to set up time to discuss in a little bit more detail with the folks from that team that are leading this work.
Thank you.
Thanks, Niels.
Laura.
This question may predate anyone here that can actually answer it. Looking at that was here in 2016, and it just felt very surprising when the law passed and suddenly we couldn't get data from the self-funded, and it was a very significant drop in our coverage in terms of our ability to access greater percentages of the data in Massachusetts. I don't recall, I knew at the time that there was some aspect of the law that said without permission. And I think we ended up in a space where we just said, this isn't feasible to go back. Nobody was willing to do it on behalf of all of their employees, for example, and go get a permission. Was that just not feasible to even attempt to meet the requirements of the law? And maybe that is just water under the bridge. I still look at that 50% and it kind of kills me. Meredith, I know that you were here at the time too. And I think we just kind of agonized over, oh, wow, I can't believe this happened, but it did. So I'm just thinking that the question being, I'm assuming no one from those self-funded companies would remotely want to take on any risk that says we're going to go get permission or we're going to do a blanket consent and we're going to send it in. I think it was just maybe it was just technically not feasible, and we just have to live with the idea that it's going to be a 50% drop.
Mm-hmm. So my understanding is that we have about 35% of the self-insured market. Now, with the caveat that a lot of that is the Group Insurance Commission, the GIC, but other accounts employers have submitted voluntarily. So
okay.
It's not a sort of total loss, but and there's certainly opportunity for improvement. But we do know that we have some voluntarily reporting. With the majority no longer reporting under that decision.
So we must have a bigger percentage of self-funded than I really understand.
I don't believe you had to get the individual consumer or patient approval. It only had to be the employer.
Did it have to be the employer? Okay.
And I think, I think, and the question is, could we have gone out and done a much more aggressive campaign about why it's in your best interest, which is what we'd spent some time talking about.
Yeah.
To do it. But it's still a good question that's out there.
I'm just thinking that there must be a very greater percentage of self-funded, because if we have at this point 50% of the commercial market, I sort of assume that none of the self-fundeds came in, but it sounds like they have. And certainly with 35% of them, then we have even a smaller portion of the non-self-funded commercial market, it sounds like, than I would have assumed otherwise. Yeah, and no, it's just, I'm just agonizing over that.
No, we spent hours agonizing. I remember those conversations.
It's shared agony, and I think that it's something that, we'd be willing to sort of reconsider. Are there other strategies that would help increase the number of employer self-insured accounts that are voluntarily reporting information? So perhaps that we can sort of put that topic in sort of parking lot for an upcoming meeting to think about what are various strategies that we could pursue to increase that the reporting rate for those self-insured accounts.
Unless Brent has an idea.
Yeah, to what extent?
It's more not so much about sort of extending, sort of trying to get more, which I sort of coverage, but it's more in I'm sort of interested in, it's very important to know probably what the differences between the people that we don't get data on compared to the ones that we do, right? And I'm sure there's various ways of trying to sort of statistically understand the people that aren't covered, you know, or that we don't get the data from, in order to sort of see how that impacts the, you know, sort of the overall information that we have. So I'd be interested in sort of hearing about sort of if we try to do, if CHIA tries to sort of do that sort of evaluation, understand which are the people we don't get data on.
Yeah, this might be worth coming back to next time, because there was a discussion about, can we use some sort of a algorithm or analysis that said, okay, the odds are they're X% different because Y, and an underwriter who would look at this would say it's a healthier population because they are, you know, working in big employer places, et cetera, et cetera. And therefore, maybe you can make an adjustment, an assumption that it's not wildly different, or it is different. But at least it's a good question. Thanks for reminding us, Laura.
Yeah, and we do have some data in the annual report that does sort of some comparisons around, I think like cost sharing and high deductible trend, things like that, comparing self-insured to fully insured. So, you know, I think point well taken in terms of, are there ways that we can extrapolate based on the data that we do have, and then we should have revisit the conversation about strategies to engage sort of more self-insured accounts to increase the reporting of their data.
Other thoughts on the EAPCD? I guess I'm going to ask you to dive into the more boring and mundane operational issue here. If I think I understand it, so I'm feeding back what I think I understand is we're doing a reset, which means that, yes, it's been a multi-year, spending a lot of money, so something's not going well. The answer to that has been to reorganize both the vendor and us. Stop me if I'm not hearing this correctly. Is it an issue primarily with the vendor? Is it an issue with both? Is it an issue with us? And is the issue that we are simply not seeing the performance of the system that we would hoped at this time? It's too slow, or is there a more fundamental flaw that we should think about? So that was a series of questions and Jamie, you're new on the spot, and so too are you, Laura. So we will take it, you know, understanding that you are still in the process of digging in.
Sure. So I can take the first sort of pass, and then Jamie, feel free to chime in. So I would say to your question about sort of where the issue lays, I would say that we use this opportunity, sort of a change in leadership at CHIA, the transition to sort of hit the reset button, because I think that there were, I would say, primarily issues with the vendor, where IBM, as many of you are probably familiar, I think we originally had contracted with Truven, and then Truven got acquired. And so there's been sort of large corporate organizational changes on their end. I think that they were not, things were limping along through the development phase, just to be sort of blunt. And I think that we use this as an opportunity to say, all right, how can we make sure that, given that this is sort of an octopus with many tentacles touching sort of the different analytics team here, the data operations team here, given all the various sort of individuals involved from CHIA, we said, let's have one point of contact that's sort of accountable to tie and coordinate all of the various aspects on CHIA's end. And let's sort of hit the reset button with IBM to make sure that they know that we are, you know, we're taking this seriously. We're going to be set very sort of clear deadlines and milestones as to when we expect things to be delivered, and when we expect performance to improve, so that they could not sort of be the one sort of dictating what the timeline and sets of deliverables or standards were. So I think it was I don't know that I would sort of point fingers on one side or the other to say this is where the issue stemmed. I would say that we use this as a collective opportunity to reset and set some clear paths forward. I think to your question about, is it performance issues or are they just not doing certain things? I would say it's probably more on the performance side, where one of the examples Jamie mentioned was the return time, or the time to sort of provide a response to a given query. So those are things that we're setting expectations, and we want to see that performance improve from the levels that they're at right now. But Jamie, anything that you would add there?
Have you unmuted? Thank you.
Yeah, I couldn't, my mouse disappeared, sorry. Yeah, no, I would agree with that. I think, as Lauren stated, a lot of things had sort of shifted and changed, but IBM has been very dedicated partner. With the Tableau performance issues, I think some of it is that we have a lot of data. And so we need to sort of fine tune the system to be able to process that much data and return queries ad hoc, which is a lot of technical work, because when you have canned queries, you can kind of set the system up to return quickly. Whereas if someone is saying, let me check out A, B, and C, that maybe is just off the top of their head, it takes a little bit longer. So we're trying to figure out how to fine tune so that people aren't waiting a long time to be able to just explore and play around with the data. So I think that, they're not accustomed to maybe having that much data passing through it. And so on their side, they're challenged with trying to figure out how to speed it up versus our expectations. So I think we've made a bunch of improvements recently, and we're coming up with a game plan to continue down that path. So I think that over time, we'll be able to continue on that journey of improving the performance, because it is kind of a back and forth process always when you're dealing with this much data. It's a lot to process through a system.
So you're still optimistic that these are performance issues that can be managed and not any fatal?
Absolutely. I think that we've made some discoveries over time as we're investigating in. They've made some changes that have been applied to improve certain aspects of it. We're continuing on that journey. They've added more Tableau focused people that have a little bit more expertise in that system, that are sort of looking at it, as an overall picture to see where there could be things tightened up or altered to make the returns faster. So I think we've been seeing some improvements over time, and we're continuing to work together to keep, making improvements as we go.
Okay, that's great.
The data itself looks good, though. It's all functioning really well. It's just, trying to speed it up a little bit.
Okay. And you'd mentioned that you have now firm deadlines, milestones, dates. So do you have them that you could share with the council?
So we have a little bit of a staggered date because we have priorities in order for them. So we gave them the order in which we want them to attack. So we're planning on all of them being wrapped up in this fiscal year. So we have some of our last major enhancements that they're working on currently, which is our main focus. Those are kind of being worked on now, over the next month or so. And then there are things that they can't be worked on until that part is finished. So they're sort of in the order of precedence through the end of the fiscal year.
So then, but the end of, so when you're saying like July 1st, staggered, they'll all be done.
Yes, that's the goal.
And you'll probably have a punch list at the end anyway, but
Yep.
the major thing will be done on July 1st.
Yes.
So at our next meeting, we declare victory.
Yeah, I think that by the next meeting, we'll definitely have, a different picture to paint at that point. Because like I said, the few last big things that we're working on are underway, and, they're being tested and things like that. So over the next couple of months, we'll definitely have made some good progress there.
Great. I think I am going to push you a little. When you say good progress,
I'm
Does that
sorry,
mean-
wrong wording. So some of
If you're
these.
talking to a woman, if you don't give me dates and numbers, I start twitching.
I apologize. No, over the next month or two, we have a punch list that are due to be completed.
Great. Thank you.
You're welcome.
And I think Martha wants to chime in.
Yeah, well, I had a question that maybe just speaks to my own, just coming in midway on this project. Is this the first time that we've done this kind of level of update to the APCD since it was stood up in what, 2012, 2013?
Oh, no, we had, to be honest, we haven't for the last couple of meetings. It's been but we had some very long meetings where we actually saw the entire work plan.
Oh, yeah,
But I think you're,
this capital engagement, like, is this the first time that this whole undertaking with IBM, this sort of thing, this is the first time we've kind of updated?
yes.
Okay.
Yeah.
That's helpful to know. And then is there any kind of expected timeline as to when, are we gonna, this is about 10 years from when it was first implemented. Is there some kind of thought as to, is there any plan for like a regular updating of APCD in this sort of thing, like some kind of 10-year schedule or something like that, or more ad hoc? Just curious about what that plan is. And also, if that's not in place yet, that's totally fine. Just curious.
So I think that we view this capital project as really sort of a major, once it's not something that we would sort of envision doing like a regular update to, in terms of this was a wholesale enhancement to the analytic capacity of the APCD. Now, once we move, so it's certainly, I would sort of qualify as a once in a decade. Don't quote me on those numbers, but once in a decade-ish, like wholesale update and improvement. Now, with that said, once we get beyond the development phase and move into the operations, we will have the ability, now working with IBM, Tableau folks, to make sort of incremental analytic enhancements and functionality. And again, that's an area that would be helpful to get the council's feedback on. So we will be able to make those incremental improvements and enhancements going forward. But this is sort of the foundation to be able to incorporate those types of enhancements and functionality.
Got it. That's helpful. Thanks.
Yeah, fair. This was a big one.
Mm-hmm.
And thank you. And welcome, Jamie, to the project.
No pressure, Jamie.
Yeah.
None at all.
It's good to be the leader.
No, Jamie has been instrumental in sort of wrangling this project and getting us on track. So I think we all feel confident in the direction and so the responsiveness that an re-engagement that I would say we've seen from an IBM. They've all of a sudden sort of come with resources to bear and putting more sort of senior folks on this project and engaged in this project, which is a promising sign to us.
I think there's also just such a value in kind of new eyes, people coming in, looking at it from completely different. Sometimes you get in the middle of all these things and you get kind of lost in the milieu and in the really tough work of doing the projects. It's really an opportune time with new leadership coming in and new leadership with a project coming in to be able to do that kind of look back where you weren't involved in all of that. And it's a fresh eyes.
Yeah, that's good.
Absolutely. So we hope to have sort of even a more progressed update to share at the next meeting. And hopefully we will be sort of at or, within inches of the goal line when we meet next in June or July.
That's great.
All right. No other questions. Shall we dive right into the last agenda item?
Yes, please.
All right. So I will just kick us off here and then turn it over to my colleague Molly Bailey. But we wanted to provide some highlights from this year's annual report that I mentioned we released or issued last Monday. And then as part of the benchmark setting process with HPC, CHIA, I was joined by colleagues to present at HPC's benchmark hearing. So we presented the findings from this 10th annual report at the benchmark hearing to sort of inform the discussions and policymaking around where to set the healthcare benchmark and taking, help to inform the conversation around trends with utilization, spending, and the like. But just again, as a level set particularly for some of our new members, the CHIA's annual report and the 2023 annual report represented the agency's 10th annual, which is an exciting milestone, and is the agency's most cross-cutting publication, which not only includes the calculation of total healthcare expenditures, which is part of the framework established in Chapter 224 of the Healthcare Cost Containment Legislation, but the report also examines trends in costs, coverage, utilization, to help evaluate system performance against the benchmark and inform policymaking more broadly. So just to sort of note at the outset, the findings in this year's annual report present data through 2021, which we all know is a time in the healthcare delivery system that it was very dynamic. The system as a whole and the policies put in place to support it were rapidly evolving in response to the COVID-19 pandemic. And so in light of this, we modified our approach to this year's report sort of in two regards. One, given the significant shifts in enrollment during this time period, notably commercial payers saw declines in enrollment, while Mass Health saw significant increases in enrollment due to federal requirements for continuous coverage. So in acknowledgement of these shifts and their material impact on total medical spending, we include in this report sort of per member per month spending in addition to the per capita and aggregate trends. Because, for example, while Mass Health spending looks like it grew significantly during this time period, when you look at it on a per member per month basis, the enrollment increases were outpacing the spending increases. So on a per member per month spending, look, that trend is actually negative. So that was one area where we sort of modified our approach to account for that nuance. And the second area, and probably more significantly, given the impacts of the pandemic on the healthcare system, specifically depressed utilization in 2020, followed by a rebounding effect in 2021, CHIA calculated total healthcare expenditures and analyzed other relevant metrics on an annualized basis over the 3-year period between 2019 and 2021 to provide a more accurate and contextualized picture of healthcare spending and utilization. So again, had we just looked at 2020 to 2021, we would have seen a much more significant increase of about 9%. But looking at that does not show the whole or really accurate picture because utilization was so depressed in 2020. And so 2021, those trends are really just a rebounding effect. So that is why we took a holistic approach to show the period between 2019 and 2021 throughout our analyses. So with that, I will turn it over to Molly, who will sort of just touch on the highlights from the report.
Great, thanks, Lauren. So hi, I'm Molly Bailey. I'm an associate manager on the Health Informatics and Reporting team at CHIA. I'm going to walk us through some high-level findings from the annual report. So on the next slide, we'll jump right into the top-level findings. And here we see that THCE increased in 2021 to $67.9 billion, coming to $9,715 per resident. As Lauren mentioned, this put the 1-year THCE per capita growth rate at a 9% increase. But when we look back at the trends across a 3-year period, THCE per capita grew at an annualized trend of 3.2%. All 3 major components, commercial, Medicare, and Mass Health, saw spending increases from 2020 to 2021, which resulted in positive annualized growth for these components when looking at the 3-year period. However, when considering enrollment trends, per member per month spending for Mass Health declined as enrollment increased in both 2020 and 2021, and these enrollment increases outpaced spending increases. For commercial, spending on a per member per month basis increased, driven by a dramatic 12.2% increase in aggregate spending in 2021, despite enrollment declines. Medicare PMPM spending increased as enrollment increased only slightly during this period. NCPHI, the gray bar at the top, known as the net cost of private health insurance, saw trends reverse in 2021, which we'll dig into a little bit later in this presentation. So on the next slide, we're going to look at total healthcare expenditures broken down at a service category level. So this represents spending for commercial, Mass Health, and Medicare all rolled up. And here we see that all claims-based service categories experienced spending increases from 2020 to 2021 as utilization rebounded. In 2021, hospital outpatient, physician, and non-claim spending experienced the greatest reversal in trends, resulting in lower annualized trends for these categories. Spending for other professional, which represents non-MD providers such as nurse practitioners, physical therapists, licensed psychologists, grew 15.9% in 2021. This category showed the highest proportion of telehealth spending, and payers cited increased behavioral health visits were a primary driver of spending growth in this category. Pharmacy was the only category that did not experience fluctuations in trend, as pharmacy spending increased over both years on both a gross and net of rebates basis. So seen on this slide, net of pharmacy rebates, spending increased at an annualized rate of 7.5%. When we look at it gross of rebates, pharmacy spending increased at an annualized rate of 9.6%, growing at an accelerated 11.1% in 2021 alone. Pharmacy rebates increased during this time, growing from $2.3 billion in 2019 to $3.1 billion in 2021. On the next slide, we're going to shift focus a little bit to some affordability metrics. So looking at some private commercial metrics for individual purchasers and employer-sponsored insurance in comparison to affordability indicators such as wages and salary and regional inflation. We see that from 2019 to 2021, premiums increase at a faster annual rate than both wages and salaries and regional inflation. However, it is important to call out that at the same time, claims covered by payers and self-insured employers grew faster than premiums. So this relates back to the NCPHI trends shown on the first slide, which reflects non-medical expenses and surplus, and can also be thought of as the difference between premiums and claims. And over the same 3-year period, member cost sharing remained below both affordability metrics, and despite a rebound in 2021, member cost sharing remained below pre-pandemic levels. On the next slide, shifting gears slightly to utilization, this slide shows the total number of all inpatient discharges and average length of stay by quarter between October 2018 and September 2022, representing data from the Massachusetts Acute Care Hospital Case Mix database. Prior to the pandemic, inpatient hospitalizations were relatively stable, and declines in inpatient utilization coincided with peak periods of COVID cases and directives to suspend non-essential elective periods. Therefore, these drops in volume were mainly attributable to a decrease in the number of adult non-obstetric planned admissions for procedures such as hip and knee replacements. During the same period, we saw an overall increase in the average length of stay, with greater increases during periods of peak COVID cases. This can be attributed to a number of factors, including the type and severity of conditions, as well as the throughput challenges. And this increasing length of stay variable is the primary driver of hospital capacity strains seen over the past few years. On the next slide, we'll look at financial metrics for hospitals, and consistent with last year's report, we included hospital financial data to the annual report to give context to financial performance and the impact of the pandemic. This year, to give a more recent look, we've included quarterly financial data through June 30th, 2022, which represents 9 months of hospital fiscal year 22 data. The total margin includes both operating and non-operating, so investment activity, as well as state and federal COVID relief funds reported by the hospitals. The statewide median total margin increased to 5.2% in fiscal year 2021 compared to the prior year, but decreased notably in the quarterly data available through June 30th of fiscal year 2022. These trends in total margins were largely influenced by non-operating margins, including investment activity during 2021. Additionally, in fiscal year 2021, total expenses increased 7.1% from the prior year, driven by a number of factors, including increasing labor costs. And the data through June 30th, 2022 is indicating that expenses were growing at a faster rate. And then finally, there are new sections added to the annual report this year, including a new chapter on behavioral health, which was pursuant to the passage of the mental health ABC legislation, and includes metrics on capacity, utilization, and spending. There's also a new analysis of telehealth spending from 2019 to 2021 to show the impacts of the pandemic on care delivery in the state. And then there's also a new section on spending for COVID-19 treatment, testing in labs, and vaccine administration as reported by commercially administered health plans. And that's the end of the very quick presentation that tried to give an overview of a 150-page report, and happy to take any questions at this time.
So this was the presentation that was given last week to the HBC in summary.
In a bridged version, yeah.
Okay. Any questions from anybody? They then take this and decide what to do with it.
Yes. I think that this is sort of serves again as a foundational source of information for the legislature, HPC, and other policymakers to sort of develop recommendations for where we go from here. Understandably, I think that there was a lot of dialogue and questions around how do we make sense of this data? How do we make sort of heads or tails? Because we're seeing these really challenging sort of capacity constraints and very dynamic fluctuating utilization levels. But at the same time, the affordability and sort of cost sharing, enrollment in high deductible plans is continuing to go up. And so how do we sort of make sense of it all? And so I don't know that any one person came out of the hearing with the silver bullet solution. But I do know that one of the questions posed and one of the things that I think we at CHIA should be thinking about, one of the things that we would be great to have the council's feedback on is, given where we are right now and given sort of the established metrics in areas that we're looking, are there other data points or metrics we should be tracking or incorporating into this annual report to help provide that comprehensive, holistic view of the system? I think one of the areas that we preemptively have identified just from conversations with stakeholders and have committed to sort of chasing down is getting more granular data on providers' cost structures. So specifically looking at how can we better track the costs that go into contract labor versus full-time FTEs, for example, so that we're able to do that double click into provider finances. I mean, we saw the sort of grim picture that those the hospital total margins sort of present, but at the same time, we really need to understand what's beneath that. And so one of the things that we're working with MHA on is how can we incorporate into reporting a more granular look at cost structure and some of particularly the labor trends that we're seeing, where hospitals are spending 4, 5, 6x on contract labor than they were 3 years ago. So that's just one example of an area that we're looking to refine the measures that we're collecting and reporting on to better reflect the current healthcare landscape, but would welcome your input either now or at future meetings as to other areas that we could consider capturing to, again, better reflect the time that we're in right now.
That's great. Yeah, was it today's paper that had the article on contract labor? Yeah.
It's been a hot topic. I can't remember if it was today or there's been a couple of articles, and I know that MHA recently released a report on contract labor costs. So I think that's helpful, but I think for CHIA, we're thinking about how do we systematically and routinely incorporate this into our existing reporting streams, so that we're providing some critical data that is again reflective of the challenges that the system is faced now, more so that they were back in 2012 when CHIA's enabling statute and a lot of the reporting streams were first constituted.
Okay. Are there any other questions on any other topic? Because I believe this was the last on our agenda. Thank you, Lauren. You've given us, and staff, and Molly, and everybody else, and Jamie in your new role, and Emma. Thank you. Lots and lots of things for us to think about. I think we'll have a robust conversation at our next meeting. And I look forward to that. Do I hear a motion to adjourn?
So moved.
Seconded.
Thank you. I am sure all in favor?
Aye.
Bye-bye. Thank you again, Laura.
Thank you, everyone. Look forward
Thank
to talking soon.
you.
Thank you.